In next 30 minutes or so, I'm going to talk about MRI and ultrasound of peroneal tendon injuries. And the purpose of this study is to describe the normal anatomy of the peroneal tendons at high-resolution ultrasound and MRI, and to recognize different types of peroneal tendon injuries and lateral ankle instability at high-resolution ultrasound and MRI. And then I will talk a little bit about treatment options, and finally I will say a few words about the ganglion cysts about the ankle. Starting with normal anatomy, as you know, peroneal tendon complex is located at the lateral aspect of the lower leg, ankle and foot, and consists of the Peroneus brevis muscle and tendon, with tendon inserting at the fifth metatarsal tuberosity, Peroneus longus muscle and tendon, with the tendon extending along the plantar aspect of the foot through the cuboid groove to insert at the base of the first metatarsal, and with some fibers also on the neighboring bones. Then the common peroneal tendon sheath, which envelopes the peroneal tendons in the retromalleolar groove and splits into two sheets at the level of the peroneal tubercle. And the distal extension, especially of the longus, is variable. Then we talk about the superior peroneal retinaculum, which extends from the lateral malleus to the calcaneus, but there is variable insertion of the posterior aspect. Inferior peroneal retinaculum at the lateral aspect of the calcaneus, which extends to the region of the sinus tarsi, and then variably present os peroneal. So to image the peroneal tendons, we can use both MRI or ultrasound, and they do both good job in evaluation of the peroneal tendons. MRI of the ankle is typically performed on 1.5 or 3 Tesla MRI machines in dedicated ankle and foot coils, and patient is typically in the supine position with approximately 20 degrees of plantar flexion. We do image the ankle in 3 planes, axial, coronal, and sagittal, and we use both T1-weighted and fluid-sensitive sequences, and also we add one gradient echo sequence with thin cuts for evaluation of the ankle cartilage. And this is the ankle and foot coil, which we use at our institution, and this is my foot in the coil. Regarding the ultrasound, it is performed again using the high-resolution linear probes, and in our institution we use 8 to 18 megahertz linear hockey stick transducer. I like that probe because it has a small footprint and can accommodate the curved surfaces. The patient is in supine position with semi-flexed knee joint and ankle internally rotated for evaluation of the peroneal tendons, and we do start imaging in the short axis and typically include at least myotendinous junction, progress distally, and examine both tendons to the level of the peroneal tubercle when they split, and then individually each one of them, and then we examine the tendons in the long axis. The plantar aspect of the Peroneus longus tendon is best examined with the patient in prone position. How the normal tendons look like, they show low signal intensity on all MRI sequences. On the sequences with short TE, we can have a falsely increased signal due to magic angle effect, because you know the magnetic field is at 55 degrees with respect to the collagen tendon fibers. And on ultrasound, normal tendons have hyperechoic fibrillar echo texture, and also it could be hypoechoic if the ultrasound beam is not perpendicular on the examined structure due to anisotropy, and this is corrected with proper positioning of the transducer. So now we start with the normal anatomy, and I will show normal appearance of the Peroneus brevis and longus tendons in the retromalleolar groove, and note here that the brevis has somewhat crescentic appearance, which is normal, and you see a little bit of Peroneus muscle belly, Peroneus brevis muscle belly. And Peroneus longus tendon here is a little bit more globular, and if you look over here, there is a thin band of superior peroneal retinaculum. As we go further down, you can observe the inferior peroneal retinaculum at the lateral aspect of the calcaneus, and you can see the longus and brevis tendon with nice low signal intensity, and also two bony protuberances, more posteriorly retrotrochlear eminence and more anteriorly peroneal tubercle, which should not measure more than like a 5 millimeters in height. Other than that, they will be hypertrophied. If we wish to examine better the plantar aspect of the Peroneus longus tendon, then that is done a little bit different way, examining the foot with the long axis plane, paralleling the long axis plane of the metatarsal bones. You can see over here on the T1 and fluid-sensitive sequences, nice Peroneus longus tendon coursing through the peroneal groove. And here on the T1 weighted image, there is some increased signal intensity due to magic angle, which is corrected on the fluid-sensitive sequence. And here the T is longer than 38, so then when we kind of, trying to avoid that magic angle. Not advancing. I'll try this way. Okay, now how is this moving? I mean, this is supposed to be a movie showing the this is a short axis of the peroneal tendons, and you can see over here the longus more superficial to the brevis. So this is the longus, that's the brevis. The mouse doesn't show up, and we follow both tendons to the level of the peroneal tubercle. So in the long axis, when we examine the tendons, so this is along the lateral malleolus. You can see hyperechoic fibrillar structures of the tendons. And when you come to the inframalleolar region, again the mouse doesn't show up, you can see over here the tendon is more hypoechoic due to anisotropy, and that is frequent in the inframalleolar region. And this is the positioning of the foot and ankle for the imaging. Now on the short axis images, you can see over here the Peroneus brevis, which in front of the Peroneus longus. And then you can see that Peroneus longus is hypoechoic due to anisotropy. And here you see the superior peroneal retinaculum above the tendons. Here is the retromalleolar groove, and the yellow arrow points to the little fibrocartilaginous ridge, which deepens to peroneal retromalleolar groove at the place where the superior peroneal retinaculum is attaching. So we do examine the tendons with plantar and dorsiflexion, and we use dynamic imaging, and that helps, in the dynamic evaluation for subluxation or dislocation outside and within the groove. So here at the level of the peroneal tubercle, you can see Peroneus brevis tendon, which is proximal, and Peroneus longus, which is distal. And two tendons is difficult to get both at this plane and the short axis, not one of them to be hypoechoic due to anisotropy because of the plane. So you kind of angle the transducer, and you got them both to be hyperechoic as needed if they are normal. More distally to this point, each tendon travels alone, and the Peroneus brevis has straight course to the insertion at the fifth metatarsal tuberosity. So when we examine the lateral ankle tendons, we also look at the lateral ankle ligaments. And then here you can see the normal appearing, the anterior talofibular ligament extending from the lateral malleolus to the talus. And then you can see in the inframalleolar region the calcaneocuboid ligament underneath of the peroneal tendons, and also here I am showing the anterior inferior tibiofibular ligament. Well, good that I have some annotation, otherwise this mouse doesn't show up on the images. That's okay. So this is the examination of the Peroneus longus tendon with the patient in the prone position. And how I do this, for me the easiest way to examine this tendon at the plantar aspect is to look first for the first tarsometastarsal joint in the long axis. Once when I locate the first tarsometastarsal joint, then I angle the which may predispose peroneal tendons to be injured. And first to mention, the different shapes of the retromalleolar groove, which is normally slightly concave, and but it may be variably convex or irregular. This is kind of concave irregular, and this, like especially convex shape of the retromalleolar groove, can predispose to peroneal tendon injuries. Although there was a paper published several years ago by Zurich group talking about these normal variants in totally asymptomatic patients. So this can be associated with peroneal tendon abnormalities, but also could be seen in asymptomatic patients. In this particular case, you can see over here with this convex retromalleolar groove that there is a tearing of the Peroneus Brevis tendon and touch of tendinopathy of the Peroneus longus. Here is slight hypertrophy of the retrotrochlear eminence. In this patient, you can see on both on the axial and coronal MR images. Here is a patient with enlarged peroneal tubercle, and you can see here that this height is definitely more than 5 millimeters, and this is frequently associated, as Dr. Rosenberg has mentioned, with peroneal tendon abnormalities, particularly Peroneus longus. Also, some other anatomic variants, such as Peroneus Quartus, which is an accessory muscle seen in the retromalleolar region, which typically originates from the Peroneus brevis and has variable distal attachment site, most commonly at the retrotrochlear eminence, can cause the crowding in retromalleolar groove and subsequent injuries of the peroneal tendons, in particular the brevis. And you can see over here and also this could be asymptomatic. So this is the Peroneus Quartus. Low-lying peroneus muscle belly is another variant which can cause crowding in the retromalleolar groove, and this can variably extend distally, but if it extends more than 1.5 centimeters distal to the lateral malleolus, that we call low-lying peroneus muscle belly. Here is the short axis and then long axis ultrasound imaging of the Peroneus Quartus. You can see over here, this is the lateral malleolus, retromalleolar groove, brevis and longus, and this is the Peroneus Quartus in the short axis, and this is in the long axis coursing toward the retrotrochlear eminence. Here you can see the superior peroneal retinaculum and this fibrocartilaginous ridge. The os peroneum is variably present, and you can see that up to 30% of foot radiographs, and if you see it on the radiograph as ossified, that in about 60% of people could be bilateral. This could be seen as an isolated single ossicle or bipartite or multipartite ossicle. And what is important, that if the ossicle is bipartite or multipartite, that the fragments are not separated for more than 2 millimeters. More than 2 millimeters means, that there is a problem. And especially that separation is 6 millimeters or more, which was published by Michigan group, that means, there is a fracture of os peroneum or separation of the multipartite os peroneum. And you can see over here on a plain film, the bipartite os peroneum, which is also confirmed on the MR image. And this is the different patient with symptomatic os peroneum with a little bit of hypoechogenicity around and a little bit of vascularity. Now I'm going to talk about peroneal tendon injuries and disorders. And first of all, to mention tendinosis, which is a non-inflammatory degenerative process which can be caused by repetitive microtrauma, subfibular impingement, and chronic diseases. While Tenosynovitis represents increased synovial fluid complex in the peroneal tendon sheath associated with inflammation, and frequently seen as a result of repetitive trauma or prolonged activity, although it can be seen after acute trauma. Here is the patient with Peroneus longus tendinopathy and mild Tenosynovitis, and you can see over here a little bit of thickening of the tendon and a little bit of edema and fluid around the tendon. These are two different patients. This is the long axis ultrasound image of the lateral aspect canal showing markedly thickened Peroneus longus and also distended tendon sheath. While in the other patient over here, you can see in the short axis on the fluorescentive sequence markedly distended peroneal tendon sheath, which is kind of heterogeneous, consistent with synovitis, some flattening of the brevis, and this is the longus. Dr. Rosenberg has mentioned many of these things which I'm going to re-emphasize, and one of them is the bone marrow edema along the lateral aspect of the calcaneus associated with Peroneus longus tendinopathy, as you can see in this patient who was one of the colleagues. And you can see the bone marrow edema here and thickening and a little bit of signal heterogeneity of the Peroneus longus. This is an interesting case. This is a patient who was treated for peroneal tendon tear with tenodesis 6 months prior to this ultrasound study, but he remained to be symptomatic after the procedure and came back for ultrasound imaging. You can see here the suture material and thickened tenodes tendons, but there was markedly increased neovascularity in this region, and we call this tendinopathy. Regarding the Stenosing Tenosynovitis, there's an interesting entity. This occurs due to chronic friction of the peroneal tendons inside the narrowed inferior osteofibrous tunnel, and the resultant condition is tenosynovial fibrosis with synovial proliferation that can prevent normal tendon excursion. And you can see over here, these images were given to me from Stanford University by Dr. Catherine Stevens. I haven't seen so good case of this, and you can see over here there is a marked distension of the tendon sheath, and which looks irregular with synovial proliferation, and there are also some fibrous bends within the tendon sheath. Peroneal tendon tears should be considered in every patient who presents with chronic lateral ankle pain, and they occur as a result of trauma, including ankle sprains, in tendons with predisposing pre-existing tendinopathy, or it can be caused by repetitive microtrauma resulting from instability. Both tendons are rarely torn simultaneously. So how the tendon tears look like on MRI and ultrasound? On MRI, high or intermediate signal intensity is seen at the tear sites, and complete tendon tears show discontinuity of the fibers. On ultrasound, tears appear hypoechoic or anechoic with fluid at the tear site, frequently seen. In partial thickness tears, the tendon can be thinned or thickened with irregular intermediate or hyperintense signal on MR images, and hypoechoic internal echo texture with loss of normal fibrillar appearance on ultrasound. When associated with tendon thickening, partial thickness tear is difficult to distinguish from tendinopathy. So the Peroneus brevis tendon is more commonly injured than Peroneus brevis tendon is more commonly injured than Peroneus longus, and the most frequent type of tear is longitudinal split, frequently the result of repetitive microtrauma that leads to tendon thinning and subsequently longitudinal split, starting at the level of the retromalleolar groove, and that can travel far distally, and later on there is frequent reconstitution of the tendon. So here is the patient with Peroneus brevis longitudinal split seen on the long axis and short axis ultrasound images with two hemitendons of the brevis, and this is the longus, and sitting in the retromalleolar groove, nicely seen. And in this patient you can also see the Peroneus Quartus sitting posteromedially to the brevis. And we again perform imaging with dorsal and plantar flexion, doing kind of dynamic examination and look for motion of the tendons within the retromalleolar groove. And here is superior peroneal retinaculum. This is the same patient, MR images. You can see over here the split brevis and the longus, and also Peroneus Quartus. And this is superior peroneal retinaculum. And you can see over here the three tendons instead of two, and this is the quartus extending to the retrotorcal eminence. So this patient was treated with debridement and primary repair. Note the damage, this was young patient, and the surgeon told me there was not much damage of the tendons besides the split, and he was able to primarily repair this, and he also excised the Peroneus Quartus. This is the patient with full thickness tear of the Peroneus Brevis, which you can see over here as anechoic and hypoechoic region about the lateral malleolus, and here is the contralateral side for comparison in the short axis, and you can see normal looking longus and brevis, and here is the longus, and here is the torn brevis, and was a little bit of vascularity on parallel Doppler interrogation. A different patient with partial thickness tearing of the Peroneus brevis, which you can see on MR images and on the ultrasound images with distended tendon sheet coexisting tenosynovitis. Now, regarding the plain films, they are important, and this is displaced os peroneum with associated peroneus longus rupture. And with complete tear of the peroneus of the peroneus longus, the os peroneum may be retracted even to the level of the lateral malleolus. Also, as it was mentioned, the fractured os peroneum shows separation of the fracture fragments. You can see over here. So this gap measures several millimeters. So this is the same patient initial study, and then couple months later, you can see over here the os peroneum sitting in the cuboid groove, and later on you don't see the ossicle there, and it is displaced in the intramalleolar region. On MR images, you can miss the presence of retracted os peroneum, particularly if you look at it here on the T1-weighted images, is more obvious, but it's important to look at the radiographs. And this is the full thickness tear of the Peroneus longus, again, retracted os peroneum. So the treatment should be based on timing and chronicity of the injury, associated clinical findings, and age and activity level of the patient. Patients with low functional demands often do well with conservative treatment, such as bracing or physical therapy, while patients with high functional demands likely may benefit from surgery if non-surgical treatment is unsuccessful. So for tendinosis, which is refractory to conservative treatment, tenosynovectomy can be done. Treatments for tears are tenosynovectomy, debridement, and tubularization if less than 50% of the peroneal tendon is diseased, and tenodesis or allograft reconstruction if more than 50% of peroneal tendon is diseased. The other factor that must be addressed in treating the peroneal tendon tears is correction of alignment. Hindfoot varus must be corrected to prevent stress to the repaired tendon, which may lead to tear recurrence. And here is the patient who has a full thickness tear of the Peroneus longus tendon, which is retracted, and then he has the Peroneus brevis split. In addition to that, the patient had a bony avulsion of the Peroneus brevis from the fifth metatarsal tuberosity. So intraoperatively, you can see over here the Peroneus brevis split, retracted toward longus, and here is status post debridement and tenodesis, and then the patient also was treated with ORAF of the fifth metatarsal tuberosity and with first metatarsal dorsiflexion or sclerotomy to correct the alignment. Different patient with markedly attenuated Peroneus brevis tendon and associated tenosynovitis with marked distension of the peroneal tendon sheath, as you can see here. So there this patient also underwent surgery, and you can see over here markedly abnormal Peroneus brevis tendon, which was debrided, and after there was debrided, there was only 20% of tendon remaining. And then the Peroneus brevis and Longus tenosynovitis was performed. Few words about the peroneal tendon injuries with instability. I'm not going to re-emphasize the order classification of the superior peroneal retinacular injury, which were nicely shown by Dr. Rosenberg. But what we're looking for subluxation or dislocation of the peroneal tendons from the groove with injured superior peroneal retinaculum, or for intra-sheath subluxation or dislocation with intact superior peroneal retinaculum. And that can be in both situations with intact tendons, and that's classified as a raking type A, or if you have a brevis split, and then longus invaginated between two hemite tendons of the brevis, that's raking type B. Predisposing factors include shallow retromalleolar groove, presence of Peroneus Quartus, low-lying Peroneus muscle belly, and congenital abscess of superior peroneal retinaculum or ligamentous hyperlaxity. Ultrasound is the best study to evaluate for transient subluxation or dislocation of peroneal tendons, especially if there's intra-sheath, because you do dynamic imaging. So here is the patient with Peroneus longus longitudinal split tear. This is less common than Peroneus brevis split tear, but you can see over here two hemite tendons of the longus and intact brevis. And this patient also has chronic lateral ankle injury. As you can see over here, there is a marked thickening of the anterior talofibular, posterior talofibular ligament sum, and then very abnormal looking calcaneofibular ligament with increasing intensity and thickening. So this is a different patient, two different patients. This is a normal situation with intact superior peroneal retinaculum, and this is the patient with type 3A superior peroneal retinacular injury. And as Dr. Rosenberg has mentioned, you can easily miss this little ossicle, which is avulsed with the fibular avulsion of the superior peroneal retinaculum. You can also see the tendons are dislocated from the groove, and there is the longitudinal split of the brevis and some tendinopathy of the longus. So again, to re-emphasize how important is radiography in evaluation of the ankle and peroneal tendons. Here you can see bony avulsion of the lateral malleus with superior peroneal retinaculum being avulsed, and this is a different patient with intact superior peroneal retinaculum showing transient subluxation of the peroneal tendons within the groove itself. So let me see what I move. So here is the brevis and here is the longus, and they're kind of switching the places during the dynamic maneuver. That's the brevis, that's the longus. Usually this is followed, this is accompanied with audible click and pain. So here is something which shouldn't be mistaken for subluxation dislocation. This is the pseudo-subluxation with somewhat medial positioning of the peroneus brevis posterior to the lateral malleus. And here is the what we call raking type B, intersheath subluxation, where there are two very abnormal hemite tendons of the longitudinally split peroneus brevis and peroneus longus kissing the posterior aspect of the lateral malleus and really in the place where brevis should be sitting. Treatment options for acute subluxation peroneal tendons may be immobilization or surgery, and for the chronic subluxation, surgical options include repair of the superior peroneal retinaculum, bone block procedures, reinforcement of the superior peroneal retinaculum with local tissue transfer procedures or combination of these procedures. For the intrasheath subluxation of the peroneal tendons with intact superior peroneal retinaculum, surgical repair of tendon tears combined with peroneal groove deepening procedure with retinacular reconstruction may be performed. And just finally, a few words about the most common masses about the ankle and foot, and that is a ganglion cyst. Ganglion cyst, as you know, has a fibrous wall rather than a synovial lining, and is filled with thick viscous fluid, looks like a hair gel. And intratendinous ganglion cysts are rare, and they are related to recurrent injury with resultant mucoid degeneration and cystic degeneration. While this kind of pararticular, paratendinous ganglion cysts usually communicate with the tendon sheath or joint through a narrow neck. How they look like on MR, we see lobulated masses with simple or complex fluid signal characteristics, and if you give a contrast, they will frequently remain hence. On ultrasound, they are typically anechoic or hypoechoic with increased fluid transmission or posterior acoustic enhancement. Treatment options for symptomatic lesions means send them to Dr. Adler to do aspiration and steroid injection, and if that doesn't work, they can be surgically removed. And it's very important to look for satellite lesions during the removal because they're prone to recur. So here is an example of a ganglion cyst in the region of the inferior peroneal retinaculum. You can see over here fluid signal intensity lesion on the MR, fluid sensitive MR image, and on the long axis ultrasound image of the same patient, you see this anechoic structure with associated increased fluid transmission. And the last but not least, this was given to me by my colleague, Dr. Scalzione. I did not see a case of this. This is rare. This is intratendinous ganglion cyst formation with mucoid degeneration and longitudinal split of the brevis, which you can see kind of over here, that the space is filled with fluid or kind of mucinous material. So, in conclusion, it is important to know normal anatomy, anatomic variants, and disorders and injuries of the peroneal tendons, to know the ultrasound and MR patterns, how we approach them, and if we make the proper diagnosis, this helps the orthopedic surgeon choose the appropriate treatment options. And these are a few references which I have used in preparation of this talk. Also, I have to say that in the last issue of Radiographics, I did publish a paper on this topic, and a lot of the images I'm showing today are published in that paper. The motivation for me to start working on this was Dr. Rosenberg's work. You know, she has published so much on the ankle and foot, and was another paper published several years ago among many other radiographics addressing a lot on peroneal tendon injuries and normal variants. And I wish to thank you for your attention. And,